Thanks for joining us this month. I'm Sandy Werner. I'm one of the leadership committee that's putting this lovely Probing the Literature National Journal Club together. And today we have a couple of really great articles to talk about. First of all, we're going to have an author discussion of their article. Actually, let me go over the schedule. So this is kind of what we do every month. We'll have about 25 minutes of Article 1 presentation and any discussion or questions that you have. And then we will get into small groups, and we have another article for presentation and discussion. And then we'll come back together for about the last 10 minutes. And then hopefully people have some research interests or projects that they'd like some help on. So we have the methods consult from 3:05 to 3:45 or however long. So the rules are: mute yourself, please, or we'll mute you. Turn on your camera, and then if you can change your screen name, we'd like to know your name, your position. Are you a student, resident, fellow, or faculty, and where you're at as well. So if you have the ability to change that, that would be great, especially when we go into small groups. So I'm actually going to introduce the first article and the author. The article is The Bubble Study, Ultrasound Confirmation of Central Venous Catheter Placement. And this is just like one of those, why didn't I think of it study? This is a great idea. And the author of our study, the first author, is our guest speaker, Petra Duran-Gehring. And she is Associate Professor of Emergency Medicine and Assistant Fellowship Director at the University of Florida in Jacksonville. And after she completed her emergency medicine residency at the University of Florida, Jacksonville, she worked in community practice in Northern California, witnessing the impact of point-of-care ultrasound firsthand. She created the ultrasound program for the Department of Emergency Medicine. She's lectured nationally and has a passion for medical education, as evidenced by numerous teaching awards. When not teaching ultrasound, she loves spending time with her husband and 3 little boys. Awesome. So I'm going to turn this over now to Petra.
All right.
Here you go. Should be yours.
Excellent. Thank you. I'm going to go ahead and share my screen, and we're going to go from there. All right. Oh, go back one slide. All right. Okay, so like you said, Sandy, this is actually a really kind of a simple project, but one that I think kind of came out from, previous problems that we had in our ED. So I'm going to start by saying when we came up with the idea for this project, it really stemmed from after a kind of a crazy shift I had. So I work in a level 1 trauma center that covers Northeast Florida and Southeast Georgia. And as you can imagine, kind of crazy, kind of chaos. And so our biggest problem in this ED is getting things done efficiently. And so we kept having to wait long times for chest x-rays to get done after we place central lines. And so as you can imagine, if we can't tell if the line is in good position, then you really can't use it. So that's what kind of created our problem. And so really the question was, why do we need the chest x-ray in the first place? And really there's 2 things that kind of came to mind that we were using the chest x-ray for, which was, one, is our line in the right position? And so by looking at where that line was placed, we could say, you know what, it's probably not in the heart. So it looks like it's right above the right atrium. Sounds good. We can use it. The other thing was procedural complications. So did we cause a pneumothorax? Did we drop a lung? And so the question really came, could we reliably confirm central line placement and rule out pneumothorax faster than we could doing that portable chest x-ray? And so the idea for this study really came from that. And so there was actually a nice study that came out looking at this idea in the ICU. And so we kind of thought, well, we could probably do that. That would actually be useful if we did something like that using ultrasound to rule out those 2 things. And so there was a nice study that came out that looked at using ultrasound to confirm line placement by looking at the heart, and then also looking at the lungs for pneumothorax. So obviously we said that seems like something we could pretty much do here in the ED. And so this was a prospective study. And so we included anybody who was over the age of 18 and had either an IJ or subclavian line placed. And so to make this inclusive, because we are a residency, we actually used senior residents. We had 2 senior residents who were actually the ones who were doing the ultrasounds to confirm placement. In our ED, our residents run our resuscitation bays, so they're the ones who are usually putting in the central lines. So why not use those residents who could just immediately, right after they did the line, put their chest x-ray order and then go ahead and perform the ultrasound. So the residents who did this were residents who had already done a month-long rotation with me. And then we went back and we kind of did some more training, just talking about specifically what we were looking for and the views that we specifically wanted. And so what we were using is we use a subxiphoid view of the heart. Very, very simple. We didn't have to worry about leads or if they had, any type of monitoring on. It really didn't get in the way. So we used the subxiphoid, and what we specifically were looking for is that right side of the heart. And so we call this the bubble study. And so what that was we actually would take agitated saline. And when I say agitated, we would just literally take a 10 cc flush. And we'd have an assistant actually flush it through the distal port of that central line. And you can see here, you get a bunch of turbulence or micro bubbles. And so other studies that kind of talked about, using some sort of agitation or whatnot, but we found that if you just kind of flushed it through quickly, you got just enough agitation that you could actually see all those little micro bubbles. So that was our first thing that we kind of made sure that the resident understood. Had to be something so we could see those micro bubbles. And then there was a timing issue. So there had to be a discussion between the assistant and then the resident who was performing the ultrasound. So they would count on 3 and the flush, and we'd also do a 6-second video clip at that exact same point. And then whatever appeared on the screen was the clip that was saved. The other thing we did was a pneumothorax evaluation. And so we did that in 2 ways. One, we asked the resident to actually scan down the anterior chest, looking for lung slide. And so they were supposed to go all the way from the clavicle all the way down to the level of the diaphragm. And then we also had them do an M mode tracing on that just to make sure we weren't missing anything. And so after we all obtained our images, then we had the faculty overread. So on our worksheets, the residents would actually say what they thought. Did they think that there was, good slide? Did they think that there was microbubbles within that 6-second period? And so they would actually chart that. Then myself, as the faculty reviewer and the ultrasound director at that time, would review all those images, and I was blinded. So I didn't have any opportunity to look at what was going on. I just knew that that was one of the ones submitted for the study. And so then I gave my overread on that. And so anything that didn't have really clear images was actually not included in our final analysis. And then we had another resident who actually did a blinded chart review. And so specifically what we were looking for is when did the chest x-ray get ordered? When did the chest x-ray get done? And then when did the final read of that chest x-ray happen? So we looked at those specific times. We also looked to see on what side the catheter was placed. Was it IJ, subclavian, right versus left? Were there any complications associated with that? And then we actually went ahead and used a student's t-test to look at the differences between those times. And so what we found were we had overall 50 patients enrolled. There were 4 that ended up being excluded just due to poor images. And then so we ended up with a total of 46 patients in our final analysis. And when we had kind of done a power calculation, we knew that we needed, in order to kind of really demonstrate a difference between those 2 numbers, we needed to have at least 34 patients enrolled. So our goal had been to really get to that 50 for a nice round number. So I was glad to see we ended up with 46 in the final analysis. Of those patients, we had the average age was about 58 years. We had mostly women in this in the patient population. So there were 64% ladies. And then 91% of the central lines at that time were IJs, but only 9% were subclavians. So our total results were that ultrasound we were able to get done in a mean time of about 5 minutes. The chest X-ray from the time in which we ordered it to when it was performed took about 28 minutes. So that gave us a difference of about 23 minutes. And then the time it took between the chest X-ray being done and the time that it was read was 290 minutes, which was really long. So the whole bottom line being that ultrasound was actually pretty useful as far as being able to correctly identify which blinds were good to use. And so when we looked at that specifically, we wanted to note that we had 3 lines that were misplaced. And this is really where the data gets interesting, because on all 3 of those misplaced lines, you could actually, we had ones that were, IJs that went into the subclavian. We had a subclavian go into the IJ, and then we had an IJ that went straight across to, rather, a subclavian that went straight across to the other side of the subclavian. So those are all technically in places that were still in the vasculature, but they weren't in a place that we would be happy with later on. What was interesting is that when you looked at the bubbles, those people actually had bubbles appear on their subxiphoid view of the heart. But what's interesting is that in previous studies, they talked about how you needed to see that flush of bubbles within usually 2 seconds. And what was interesting is that in these 3 misplaced lines, they actually appeared within the video clip, so within 6 seconds, but we found that they were usually delayed by at least 5 seconds. So that started making us think that 2-second time frame is really important. And then the other one was we had 2 pneumothoraces that were what happened with these patients. So we had 2 complications from those central lines. And the good thing is that both of those were actually caught with the ultrasound. So that was actually kind of cool in that respect. So the main thing here was, we really kind of took away from this was, yes, we can actually use ultrasound to help us, but you need to be careful about the time in which you see those bubbles and how numerous they are. So the ones that were negative, that were kind of would have been false positives, or rather false negatives, were kind of showing up in a more delayed manner. So the bottom line on this was that ultrasound could be used to help us to significantly rule out pneumothorax and to rule that our line was in position. And it was much, much faster than chest X-ray, specifically in our institution, and really helped us to expedite the use of those central lines in our critically ill patients. And so that's kind of the quick and dirty about this specific study. So I don't know if you have questions. Anybody have any questions, I guess, they want to ask about this? Because you're right, this is a really simple study. And this, I think the key point on this is we saw something that was actually a really easy thing to do in the literature that was done in another location. And so would that be feasible down in the ED?
Yeah, it's a great study. I mean, it's just one of those really, and it really gives people the ability to use that. And I'm sure that many institutions are like yours, where getting that chest X-ray is not a simple matter. And, they're down doing traumas and eventually you get them, but it would be very nice, especially if you need to push pressors or give volume, to actually have that. So this is just a great study and a great contribution. Any other questions?
Maybe we just jump in.
Go ahead.
Okay.
Sure.
Thank you. Hi, Larry Melniker from NYP Brooklyn Methodist. I'm sorry I was a few minutes late. All of these patients were done in the ED.
Correct. Yes.
What happened to the 4 that were excluded?
It was just poor images. So because the residents were performing them on their own and I was overreading them, that either they just didn't have good views, like it would be a subxiphoid, and I couldn't actually see the heart. So those are the ones that got excluded specifically.
Yeah, I think in all fairness, you have to include them. You were looking to see if ultrasound could confirm the placement of the line in those 4 cases with bad images. It failed to confirm it. If they ruled out pneumothorax or ruled in, I would kind of tease that out. There's very little reason other than subcutaneous emphysema why ultrasound would fail to be able to see lung sliding. If you were able to see lung sliding on any of those 4 cases, then at least they ruled out the pneumothorax part, even though you didn't confirm whether the line was in the right place. Also, perhaps because I was a few minutes late, was the saline plunged just by hand?
Yes. So to hit both of your points, so the first one, when we, the only reason those were excluded was because we had a protocol, as far as our protocol needed to have both site images included. So anyone who didn't meet both of those things, so yes, those 4 that got thrown out of the data analysis did accurately predict whether or not they had a complication of pneumothorax. So that actually was great. As far as the subxiphoid views, that had to do, I don't know why, I can't remember back in why we excluded those specifically.
A lot of reasons why subxiphoid might fail.
That was the issue there. And then as far as how we did that, yes, the saline plunge was a 10 cc syringe of saline that an assistant actually just flushed quickly. We did not do any agitation to it. We did not do anything where, I know there was another study that looked at femoral line placement in pediatrics.
Okay.
And they actually had a Y, like a Y connector, and they would kind of go back and forth between the two to really agitate the saline and then flush it through. And when we started kind of looking at whether or not this was a feasible thing to do down in the ED, we found that we didn't really need to do that. That if we just had someone, just flush normally, that we could see those micro bubbles really, really well.
Okay. And everyone at least had a firm handshake, so there was reason to believe they
Yeah.
flushed more or less the same.
Right.
I asked that because the timing question is a big deal. And the fact that it could have been the squeeze that influenced whether it was 2 seconds or 5, that's not a whole lot of time. That's really important. If you can consistently show that the flushing was similar, and under 2 seconds meant it was really where it should be, but over 5 seconds meant I need to be concerned about this. I'm not sure where this line is. That's kind of a big deal. Just going back to the exclusions, you are required by your IRB to follow your protocol for the purpose of doing your study and listing your patients and including them in the study. You are not required to report your data as per protocol. An editor, a statistics editor, a journal, I think they wouldn't know what your protocol showed. So there is no reason your manuscript can't include the fact that you didn't see subxiphoid in 4 of them, but you did clear, I think you said 2 of them. You got images to clear the pneumothorax. Yeah, you don't need to follow your protocol when you write your manuscript. And I think it's because it was a confirmed placement with ultrasound, you should include those 4 patients in your
I think
paper.
the only reason we wrote this, years ago, but I think the reason why we didn't was because our question was, did we 2 things, like, one, did we rule out a complication, specifically pneumothorax? But then the most important question was, were those lines definitively in the right place? Meaning that I did not see the catheter tip within the right atrium. And then did I see microbubbles within the heart? And so if I couldn't see the heart, then I couldn't say definitively
but that's
that
a fail.
line's in a good position.
That's a fail, Petra.
Right.
It's like intention to treat. You had intention to see in all of them. You did not see that. That, in all fairness to the study, is a fail. And if you have to write an addendum to your IRB saying, oh, for our final analysis, we included these, which is a protocol change, then yeah, I would change the protocol. I wouldn't change, but I would include them in the manuscript.
Gotcha. Thank you.
Pleasure.
I think, and that was the other thing too, I think, we were using people who had, at the time, these were senior residents. So we really were trying to kind of target, if, our residents mostly go out into community practice, and making sure that this was something that, the average person who does not have an ultrasound fellowship could actually do in a reasonable way.
Hey, Petra, on the ones that you overread as being that you couldn't read them, did the resident who did the ultrasound feel like they were able to interpret it live or?
Yeah, I think that there was, there was a couple of things, and we kind of went back on this because we really was two residents who specifically did all the image acquisition. And so I think that when we asked about those specific images, because we allowed them to write comments or, what was limitations, anything there. One of them, I think the big issue was body habitus. And so we have, we didn't look specifically at, their BMI or even weight, but I think that played a major role in that. And then the other question is, would this have, if you had more experience, would you been able to tease out finding a different view? And so we initially kind of went back and forth as to could we use the peristernal long? And so since our question really was, we wanted to be able to tell whether or not that catheter tip was truly in the right atrium, to be able to visualize that, that we felt like that peristernal long, since you couldn't see the right atrium, would not be the appropriate, kind of view for us. Could they get an apical 4? They could, but again, these patients were usually all vented. Most of them had, were septic or, and they were just not able to roll. So even having them, could you get a apical 4 on these people and, better positioning? Those were all things that, yeah, probably could have been done. But I think the resident felt very, limited in that they didn't feel comfortable doing that.
Yeah, I think in the real world, though, that's what I think people would do, was see if they could get an alternative view. Especially if they knew it was going to be a long time for a chest x-ray. So good point.
Yeah. Yeah. And I think that we did have a couple of peristernals that were submitted, but you're like, well, I can't see it, you can't rule this out, or we can't, luckily they had put both images in there. But that was kind of, again, it was a good teaching point, and really hammer it home to our residents. This is something that you really, if you're going to use this, you have to really kind of look in other places too.
Great study. Any other questions? Thank you so much for presenting that.
I did have one quick question. I apologize for interrupting. Petra, we tried to do this study over here at Buffalo and really couldn't make it work in terms of like the research mechanics. And I think that was part of our learning phase. But all the people who performed the ultrasound, were they already on the IRB before you started, or were they? I guess that's the question.
Sure.
Can you just kind of go review when you have
absolutely.
these studies?
So when we started this study, it kind of became an a frustration of oh my gosh, we have been waiting for an hour now for a chest x-ray on a patient who really we need to go ahead and get the line going. And so it's one of those things where well, why can't we go ahead and use the line? And so we kind of tested this out and we're like, well, let's go ahead and do it. Let's see if this works. And it did. So then the question was, how can we do this in a way that I'm not as the expert performing the ultrasound? And so we had two residents who were looking for research projects and interested in ultrasound. And so they were the ones who we got in on the IRB. And actually, one of them, Kristen McKee, was the one who actually wrote most of the IRB for us. I helped her, but she was really involved and really excited. And our residents, when they're second year, kind of do a big, months in the ED where they're just in the recess bays every day as a 12-hour shift. And so what was nice is that they were on recess when we started this. And so they were able to get a bunch in. And then when they got off of recess, that's when we ended up it took longer to finish the study because we had to wait for those same people to be back on recess. Just to make this, kind of so that they would be able to do this in a more logical way. Because otherwise, somebody else is putting the line in, or they would have to kind of hang out and wait for lines to be done. So we were just trying to maximize their time. So yes, they were both on the IRB. And then we actually had a radiology resident who was interested, who started off on the IRB and then ended up transferring out at a certain point. Or transferring out of our institution to go somewhere else and he actually decided not to do radiology. So he did the initial, kind of helped with the chart review, but he didn't perform any of the ultrasound images. It was just two of the ER residents.
Okay, yeah. One of our issues was we don't have enough central lines to, like, we don't have a dedicated resus bay like that. And we were trying to get all like 30 residents to be involved, but then the IRB said, nope, can't do that. Got to have everyone cleared, and it became a big disaster.
I
So
can imagine.
your IRB required you to name everyone who was going to participate. Wow, that's rough.
Yeah.
Yeah, you tell me about
I
it.
could understand them demanding a training program that everyone who participates is going to complete as declared by the ultrasound director. Knowing, yeah, I mean, it's, where are we? We're April. If we started a study like this now, we might have different residents collecting data on patients. Yeah, that's kind of brutal.
Yeah, we only last year did we break through that case reports don't require an IRB. So that gives you an idea of where we're at.
Wow. All right.
And
Okay.
looks like somebody raised their hand. I don't know, William
Oh.
Bedard.
Hey, yeah.
You have a question? You have a question?
Yeah, I have a question. In fact, hey, hi, everybody. I'm William. I'm the ultrasound attending back in Montreal. I'm just curious because it's a really interesting study, and I'm thinking about that patient, say that we're putting a central line in the ED, and would it make you do anything different clinically if you see delayed bubbles? Like, you know, when you're in a vein, at least, like they're coming to the heart, and that guy need the level, need the happy. So will that delayed bubble apparition in the right atrium make you change anything clinically? Or like,
That's-
well, got it and we know we might need to move it at a certain point?
Well, that was a great question. And that's actually something that came up clinically that got, you think about if you're putting in a line traditionally, and you look on the chest x-ray and you see that, your subclavian went, instead of coming down into the right atrium, it's now straight across. You can still potentially use that. And so we thought that, as far as when we were kind of moving forward with this idea in our ED, it was, if you see bubbles within that, within that video clip, then the line is at least in the central location. Although if it's delayed, it's probably not in the optimal position. So if you have somebody who you really need to start pressors on or whatnot, then we would go ahead and use it. Just like if you were, if anywhere else, if you had your, subclavian, your IJ that kind of went down into your subclavian, you would probably use it temporarily until you could get a better line. And so that was kind of the discussion that we had after the study of like, what does this mean? But I think the big key point was that if you didn't see bubbles at all, then you knew that you were not in the right place or not in the vasculature, regardless of what you thought. I know that I'm sure everybody's had that where you're drawing back, and you get blood, but you're actually in a hematoma or whatnot. That's something to kind of consider. If you're not getting any bubbles, then you're not in the vasculature.
Yeah, I get it. So the apparition of the bubble is the main thing. Like whatever,
Yeah.
I think that appears at a certain point in time, so we know we're in a system, and then we can confirm and use it. Okay, perfect. I understand.
Yeah,
that.
it was actually Tony Weeks published a study kind of before we did ours that actually came out while we were actually in writing our manuscript up. That actually talked about how he timed it out and found that if they were within 2 seconds, that really kind of puts you're definitely right above the right atrium, and you're like just about to hit into the heart. But anything beyond that, you're somewhere else in the vasculature, but and you potentially have flow into the heart, but you're not in the prime position.
Perfect. Thank you so
Great
much.
question, though.
Jenna.
All right, great. Any other quick questions? Okay. I realized I was totally negligent at the beginning, and I just wanted to let everybody know that these great slides and all of the initial legwork was done by Dr. Monica Luziak, who's here, but is not coming on screen. They had a small addition to their family, and she is otherwise occupied. So I'm just stepping in her stead this month. So we're going to go ahead and move on to the next part of this. And let's see. So we're going to go ahead and divide up into small groups. And we have some folks who have volunteered to walk you through the second article and lead the discussions. So we'll go ahead and break up into small groups and let you guys discuss the second article. And then we'll kind of come together at the end and have everybody bring up the main thing that they got out of their discussion.
Awesome. We're going to open up the room in just a second. If you have any issues with your group, feel free to come back to the main room and I'll take care of them. Thank you so much.
Hey, Dan, so I'm not gonna be I can't be a moderator.
Okay, I'll take care of it.
If you'll just put that group, or if you can just break them up into other groups.
You got it.
Sorry.
No problem.
In summary or anything. Does anybody have anything that their group found or discussed that was really kind of a great salient point that you want to talk about? None?
I think the big thing we talked about a lot in our group was that it was nice to have this coming from a journal, coming from that particular subspecialty. So getting some and helping develop a program at your own place, having literature from the orthopedic journal saying, hey, this is from your guys' journal, you know, like we can do these, we can help you, we can help the patients with pain control and length of stay and everything, like, but no, this is in your literature, which I think is nice to try and get buy-in from subspecialists.
I agree. Did anyone else have a discussion about, like, most of you guys have good relationship with orthopedics? Is this something that you could actually roll out in your ED, or have you rolled out in your ED?
Yeah, our group actually, I kind of took a little bit of a informal survey, and it sounds like a lot of institutions are actually have it implemented or are in the process of having it implemented. So I think this article comes at a perfect time to have this discussed.
Absolutely. Anything else that people found interesting from any group that was kind of a salient point that you want to bring up? Because I think you're absolutely right. I think this is actually kind of a nice thing that if you have any pushback from your orthopedic surgeons, you can say, well, actually, hey, we have this and it's been done elsewhere and was quite successful. Anybody
How
else?
Amal Matu sometimes talks about, he just shakes the guidelines like they're in your guidelines.
Troy, did you have something you wanted to say?
No, we were just, our group is all pro block, and to try to get this in your own institution does require usually a kind of top-down, multi-specialty collaboration to make this happen well. And that means working with anesthesia, orthopedics, and ER kind of simultaneously and coming up with a protocol everyone's comfortable with. That's how we did it at our institution, but this is probably going to roll out at a lot of places at a system level, from the system saying, hey, we need to get more efficient with getting these patients through the whole process of getting their hip fixed. And part of that is this hip block. And so if you understand that as soon as the system starts pushing, we're all going to be doing it anyway. So that's good.
Yeah, definitely agree. Is anyone doing more than putting in a needle and just pushing in a bolus? Is anyone placing catheters for continuous blockade? Don't all speak at once or too fast.
I would love to hear if somebody is, please pipe up, because I think most of us are not. At least I'm not at my institution.
We actually had an anesthesia resident propose, sham blocks, true blocks with sham drip, sham block with true drip. Maybe not the last one, but they couldn't get very far with it.
Yeah, there was, I know, because we kind of have been working on trying to get our procedure together, and there was a paper that actually came out that when the comments back were, why would you, anesthesia had said, why would you bother, doing a single block? Why would not put a catheter in? And I think the discussion here is that that's not really what EM does. I mean, I think most of us feel comfortable with doing the block and then kind of letting them go upstairs, as opposed to putting a catheter in. I don't really feel like that's probably.
Yeah, I don't think that was a logical question, especially if you're using a cocktail, ketorolac, acetaminophen, IV or otherwise. You do one of these blocks with something long acting, by the time it wears off, you've got a few doses of your cocktail in, and there's a good chance that they would end up with a lower overall opioid load, even with the single block, which is why we're having the conversation today. It's a little bit out of our bailiwick, but I don't see any reason why we couldn't do this when anesthesia is not around to even put this. We put people on drips, whether it's insulin or pressors all the time. This really should be just another drip, done a little bit, done as carefully as the central line that you're putting in for whatever drip you need for the insulin drip.
I guess really the question is, how long are you having those patients down in how long is it going to be before they get to the OR?
That's a great question.
And I think that's really the question, at least in our institution, in a trauma center, like that can be, they can sit there for quite some time. If we have a busy Saturday night, if you get a little old lady who fell, they can be waiting 16 hours before ortho will take them to the OR, or even just, see them. So I think that kind of just depends on, I think a lot of places, they may go up much quicker than at my institution. And if they do, great.
Martin brought up that point from Nebraska, that even the single shot might delay people getting upstairs. There were a lot of things that we didn't do 20 years ago in my ER because we thought it would delay people. Like, we didn't want to provide any kind of critical care, because then the patient would never get up to a critical care bed. We have evolved to a point as a specialty where I think we can do this stuff and not in many institutions be overly concerned that we're taking such good care longitudinally of the patient that they don't get upstairs. That's a sad statement if that's the case.
I think our evolution as a specialty is dependent on our devolution as a system, in terms of we're having to do these things. I was also just going to mention one of my cases that I recall very strongly. Wow, I can't speak, I'm sorry. But he was basically a popliteal fossa tibial nerve block catheter that had become dislodged as an outpatient or an ambulatory, or I guess not ambulatory, but had been sent in from a facility. And there was nothing we could do to get his pain under control, except we gave him a single shot while waiting for anesthesia to come back in and put a catheter back in, just because that was not something that I was familiar with. It was certainly a disheartening case to be a part of, just because the catheter had failed and I didn't have the training at that time to fix it. So it was an interesting conundrum with the ED and the catheter situation.
Yeah, I think it's an interesting conversation about catheters versus no catheters. Like, I feel like this is one of the things that when we do this journal club in 5 years, we'll be saying, well, why aren't we putting in catheters? And I think, right now we're all saying, hey, we're starting to flirt with this idea, but we haven't really made it mainstream for all of our hip fractures. And, we're doing the proof of concept studies, with this and others. And then as we get more and more experience, to me, it doesn't make sense why we wouldn't say, okay, what can we do to help out? Though the question I think needs to be answered is putting a catheter in the ED helpful, or is that something that needs to be done operatively, by the anesthesia? Because like, is our catheter gonna be in the way when they go to the surgeon? I don't know enough about the procedure, and those studies would have to be performed. But it would make sense that, they're waiting in our EDs for long enough. We're not delaying things by doing things like this, but I think those studies are gonna be forthcoming as we get more and more momentum and experience. So.
Right. And I think definitely the nursing shortage and everything else that kind of has been delaying. I think most people getting people out of the ED in a timely manner is going to kind of continue to impact our patient care and probably lead to more catheter placements in the future. Okay, well, since it is time, I'm going to quickly just kind of just want to thank everybody for coming. And then the main thing I just want I have a couple more slides I think that they have up for us. Our next month. So making sure that everyone knows that next month we are doing ocular and global ultrasound discussions. So just be sure to stay tuned for that. And then the other thing is, if you want to be a small group instructor, please email me. There's also a little form if you want to fill out that we will send out or put in the chat. If you're interested in becoming an instructor, we would love to have anyone come and help us and to join us in leading this discussion. And then again, thanks again for our whole leadership team for helping out with this, and especially Monica, who is out on mat leave. And hopefully she's still kind of in the background somewhere there. Great work. And then we're going to go ahead and move into our methods consult. So thank you guys all for being here, and all of our small group instructors. Thank you. If you have a research project you're interested in presenting and want to get some feedback on that, I would highly encourage you to stay. If you have an idea or just want to get some other feedback, this is the time. No judgment. We're just here to help. And I will let Dan take over from that